Mitral stenosis. Etiology of mitral stenosis is mostly rheumatic or degenerative. Rheumatic fever is the most common cause of mitral stenosis worldwide. Its prevalence has greatly decreased in industrialized countries, but it remains a significant healthcare problem in developing countries and affects young patients. Degenerative mitral stenosis related to MSC is a distinct pathology and its prevalence significantly increases with age. Both types of mitral stenosis are more frequent in females. In rare cases, mitral stenosis due to valve rigidity but without commissural fusion may be related to chest radiation, carcinoid heart disease, or inherited metabolic diseases. Rheumatic mitral stenosis. Evaluation. Clinically significant mitral stenosis is defined by a mitral valve area less than or equal to 1.5 centimeter square. Commissural fusion with thickening of the posterior leaflet is the most important mechanism of stenosis. Echocardiography is the preferred method for diagnosis, assessment of severity, and hemodynamic consequences of mitral stenosis. Valve are using 2D planimetry is the reference measurement of mitral stenosis severity, where mean transvalvular gradient and pulmonary pressure reflect its consequence and have a prognostic role. 3D transthoracic echo planimetry may have an additional diagnostic value. Transthoracic echo usually provides sufficient information for routine management. Scoring systems have been developed to help assess suitability for percutaneous mitral commissurotomy (PMC). Transesophageal echo should be performed to exclude LA thrombus before transmitral commissurotomy or after an embolic episode, and to obtain detailed information on mitral anatomy, commissural zones, and subvalvular apparatus before intervention, when transthoracic echo is suboptimal. Stress testing is indicated in patients with no symptoms or symptoms equivocal or discomfort with the severity of mitral stenosis. Exercise echocardiography may provide objective information by assessing changes in mitral gradient and pulmonary artery pressure and is superior to DSC, dovitamin stress echo. Echocardiography plays an important role in the peri-procedural monitoring of PMC and follow-up. Now, indications for intervention. The type of treatment, PMC or surgery, as well as its timing should be decided based on clinical characteristics, anatomy of valve and subvalvular apparatus, and local expertise. In general, indication for intervention should be limited to patients with clinically significant moderate to severe rheumatic mitral stenosis where valve area is less than or equal to 1.5 centimeter square in whom percutaneous mitral commissurotomy has had a significant impact on its management. In Western countries where incidence of rheumatic fever and number of PMC is low, this treatment should be restricted to expert operators in specialized centers to improve safety and procedural success rate. Efforts should be made to increase availability of PMC in developing countries where access to treatment is limited due to economic reasons. PMC should be considered as an initial treatment for selected patients with mild to moderate calcification or impaired subvalvular apparatus, but who have otherwise favorable clinical characteristics. The management of clinically significant rheumatic mitral stenosis is summarized in figure 7, and indications and contraindications for PMC are provided in the table of recommendations below. Now, recommendations on indication for percutaneous mitral commissurotomy, that is PTMC, and mitral valve surgery in clinically significant moderate or severe mitral stenosis, that is valve area less than 1.5 centimeter square. PMC is recommended in symptomatic patients without unfavorable characteristics for PMC class 1 indication. PMC is recommended in any symptomatic patients with a contraindication or a high risk for surgery class 1 indication. Mitral valve surgery is recommended in symptomatic patients who are not suitable for PMC in the absence of futility. Class 1 indication. PMC should be considered as initial treatment in symptomatic patients with suboptimal anatomy but no unfavorable clinical characteristics for PMC. Class 2 indication. PMC should be considered in asymptomatic patients without unfavorable clinical and anatomical characteristics for PMC and high thromboembolic risk, history of systemic embolism, dense spontaneous contrast in the LA, new onset or paroxysmal F, and or high risk of hemodynamic decompensation, that is systolic pulmonary pressure more than 50 mm mercury at rest, that is systolic pulmonary pressure more than 50 mm mercury at rest, need for major NCS, non-cardiac surgery, desire for pregnancy. In that case, PMC should be considered. It is class 2A indication. Now, what is unfavorable characteristics for PMC can be defined by the presence of several of the following characteristics. Clinical characteristics include old age, history of commissurotomy, New York Heart Association class 4, permanent F, severe pulmonary hypertension. Anatomical characteristics include echocardiographic score more than 8, Cormier score 3, calcification of mitral valve of any extent is as assessed by fluoroscopy, very small mitral valve area, severe tricuspid regurgitation for the definition of scores. Now, contraindications for percutaneous mitral commissurotomy in rheumatic mitral stenosis. The contraindications are where mitral valve area is more than 1.5 cm square, in LA thrombus, more than mild mitral regurgitation, severe or bicommissural calcification, absence of commissural fusion, severe concomitant aortic valve disease or severe combined tricuspid stenosis and regurgitation requiring surgery, concomitant coronary artery disease requiring bypass surgery. In that case, it is contraindicated for PTMC. Now, the flow chart. What the flow chart indicates? The flow chart of management of clinically significant rheumatic mitral stenosis. If symptoms presents, then we will do if PTMC or surgery. Our treatment of choice PTMC or surgery. If PTMC is contraindicated, our choice is surgery. If PTMC is not contraindicated, our choice is PTMC. If contraindication or high risk for surgery, then choice PTMC. If favorable anatomical characteristics, choice PTMC. If favorable clinical characteristics, choice PTMC. If there is no favorable anatomical characteristics or no favorable clinical characteristics, then surgery is the choice. This is the for symptomatic patient. If patient is asymptomatic, then what will we do? In asymptomatic patient, if there is a high risk of embolism or hemodynamic decompensation, then our choice is PTMC or surgery. That is, if high risk of embolism or hemodynamic decompensation, our choice is PTMC or surgery. If contraindication to PTMC, we will do surgery. If there is no high risk of embolism or hemodynamic decompensation, patient is asymptomatic, we will do exercise testing. If patient after doing exercise testing patient becomes symptomatic, then our choice is surgery or PTMC. So, if patient after doing exercise testing there is no symptoms, then we should follow up the patient. Now, medical therapy. Diuretics, beta blockers, digoxin, non-hydropyridine calcium channel blockers and ivabradine can improve symptoms. So, what drugs can improve symptoms? The drugs are diuretics, beta blockers, digoxin, non-dihydropyridine calcium channel blockers and ivabradine can improve symptoms. Anticoagulation with vitamin K antagonist with a target international normal ratio INR between 2 to 3. is indicated in patients with AF. Patients with moderate to severe mitral stenosis and AF should be kept on vitamin K antagonist, that is warfarin, and not receive NOACs. Currently, there is no solid evidence to support the use of NOACs in this setting, and a randomized clinical trial is underway, the Invictus, VK and CT. Neither cardioversion nor catheter pulmonary vein isolation are indicated before intervention in patients with significant mitral stenosis, as they do not durably restore sinus rhythm. If AF is of recent onset and the LA is only moderately enlarged, cardioversion should be performed soon after successful intervention. It should also be considered in patients with less than severe mitral stenosis. Amiodarone is most effective in maintaining the sinus rhythm after cardioversion. So, amiodarone is the most effective in maintaining the sinus rhythm after cardioversion. In patients in sinus rhythm, oral anticoagulant is recommended when there has been a history of systemic embolism. So, in patients in sinus rhythm, oral anticoagulant is recommended when there has been a history of systemic embolism or a thrombus is present in the LA, and should also be considered when transesophageal echo shows dense spontaneous echocardiographic contrast, or an enlarged left atrium. What does the enlarged left atrium indicates? In M mode, if its diameter is more than 50 millimeter. In M mode, if its diameter is more than 50 millimeter or LA volume is more than 60 ml per meter square, in that case oral anticoagulation should be given. So, in patients in sinus rhythm, oral anticoagulation is recommended when there has been a history of systemic embolism or a thrombus is present in the LA, and should also be considered when transesophageal echo shows dense spontaneous echocardiographic contrast on an enlarged LA. What does the enlarged LA means? Enlarged LA means in M mode diameter is more than 50 millimeter, or LA volume is more than 60 ml per meter square. In that case, oral anticoagulation should be recommended. Now, serial testing. Asymptomatic patients with clinically significant mitral stenosis should be followed up yearly, by clinical and echocardiographic examinations, and at a longer intervals, 2 to 3 years in case of moderate stenosis. So, if patient has clinically significant mitral stenosis, he should be followed up yearly in asymptomatic patient. If moderate stenosis, he should be followed up 2 to 3 yearly. Follow-up of patients after successful PMC similar to that of asymptomatic patients, and should be more frequent if asymptomatic restenosis occurs. Special patient population. When symptomatic restenosis occurs after surgical commissurotomy or PMC, re-intervention in most cases requires valve replacement. But PMC can be proposed in selected candidates with favorable characteristics if the predominant mechanism is commissural fusion. In patients with severe rheumatic mitral stenosis combined with severe aortic valve disease, surgery is preferable when it is not contraindicated. The management of patients in home surgery is contraindicated is difficult and requires a comprehensive and individualized evaluation by the heart team. In cases with severe mitral stenosis associated with moderate aortic valve disease, PMC can be performed to postpone the surgical treatment of both valves. In patients with severe tricuspid regurgitation, PMC may be considered in selected patients with sinus rhythm, moderate atrial enlargement, and severe functional tricuspid regurgitation secondary to pulmonary hypertension. In other cases, surgery on both valves is preferred. In the elderly population with rheumatic mitral stenosis, when surgery is high risk, PMC is a useful option even if as palliative care. Treatment of patients with low gradient severe mitral stenosis, that is low gradient severe mitral stenosis, that is mitral valve area less than 1.5 centimeter square and but mean gradient is less than 10 millimeter mercury, is difficult as these patients are older and have less optimal anatomy. Now, degenerative mitral stenosis with mitral annular calcification. Mitral annular calcification is a distinct entity that differs from rheumatic mitral stenosis. Usually, these patients are elderly and may have significant comorbidities including disease of other valves. Overall, the prognosis is poor due to high risk profile and technical anatomic challenges resulting from the presence of annular calcification. Between 9% and 15% of the general population may have mitral annular calcification with higher frequency in elderly patients. Furthermore, almost half of patients with aortic stenosis undergoing TAVI have mitral annular calcification and the disease is severe in 9.5% of cases. Severe mitral annular calcification may result in mitral stenosis more frequently or mitral regurgitation or both. Now, evaluation. In patients with degenerative mitral stenosis and mitral annular calcification, the echocardiographic evaluation of the disease severity is difficult and the usual parameters lack validation. Planimetry is less reliable due to diffuse calcium and irregular orifice. The mean transmitral gradient has been shown to have prognostic value. For the evaluation of severity, it is necessary to take into account the abnormalities of LA and LV compliance before indicating an intervention. If an intervention is planned, echocardiography is used for initial evaluation and CCT is necessary to assess the degree and location of calcification and to evaluate the feasibility of an intervention. Indications for intervention. Treatment options including transcatheter and surgical approaches are high risk procedures and evidence from randomized trials is lacking. Even if the procedure is done successfully and the transvalvular gradient is reduced, due to low compliance of LA and LV, the mean atrial pressure may remain elevated. In elderly patients with degenerative mitral stenosis and mitral annular calcification, surgery is technically challenging and high risk. As there is no commissural fusion, degenerative mitral stenosis is not amenable to PMC. In symptomatic inoperable patients with suitable anatomy, preliminary experience shows that transcatheter mitral valve implantation in mitral position using an inverted balloon expandable TAVI prosthesis is feasible in selected patients with severe mitral stenosis when performed by experienced operators after careful pre-planning using multimodality imaging. The largest case series reported to date included only 116 patients. However, operative mortality is high, in particular due to the risk of LVOT obstruction, and midterm results are less favorable compared to mitral valve involved procedures. The most recent case series show that results are improving owing to better patient selection and the use of different accesses, as well as concomitant or preventive measures such as alcohol septal ablation or laceration, resection of the anterior leaflet. Recently, a preliminary case series suggested that transcatheter mitral valve replacement using a dedicated prosthesis is feasible and can result in symptom improvement. Thank you.